Seasonal influenza is something that happens every year. The H1N1 strain from 2009 actually is part of now our annual seasonal influenza. It's still around. It comes and goes in the seasonal flu months. The same thing will probably happen with COVID-19 once we get through this first wave of epidemic. So seasonal influenza is less lethal and a bit less contagious than COVID-19. So for COVID-19, more people will become infected from a single person, especially because right now there's no population immunity at all in the United States. The mortality rate is a bit higher, but that may turn out to be an artifact. We know that in Hubei province, where this started, the mortality rate was quite high in the 3–4% range. In countries where there has been adequate preparation before the virus came, like Hong Kong and South Korea, the mortality rate is actually much lower. Not as low as the 0.1% of seasonal influenza, but probably it's going to end up being less than 1%. Everyone should take this epidemic seriously. Anyone can get this infection, anyone can spread it. You have to be particularly careful about those who are immunocompromised, who are elderly, who may have chronic heart disease, chronic lung disease, a smoker, a diabetic, and particularly elderly folks, so your grandparents for the young folks. Those are individuals that are particularly prone to having bad outcomes from this virus. Young people themselves will probably become ill. It is true that anyone can become severely ill from this virus, but the young people are much less likely to do so than the elderly or the immunocompromised. So the original testing algorithm from DOH and CDC was basically you test it if you are a known contact of someone who is an actual case. If you are in the hospital with cough and fever without a diagnosis, and particularly if you're severely ill on a ventilator. And preferably you have some sort of travel history to one of the areas that is endemic for COVID-19. What's happening now that testing is becoming more available is that patients who are sick, they have cough, they have fevers, they may or may not have a travel history to an endemic area, but preferably they do, but not sick enough to be in the hospital. So traditionally the state health department would not test those patients. We're trying to get testing out to some of those patients now. It's important for two reasons. One is to identify the diagnosis, and secondly to make sure that contact tracing and quarantine is done properly. So remember that this virus is very contagious. The pace of the epidemic is what's of most concern. The fact that it has spread from a single market in China to a worldwide pandemic in 2 months is remarkable. The risk there is that if the epidemic produces so many sick people in a very short period of time, that will overwhelm our health system, as is now happening in Italy. Social distancing in terms of canceling events accomplishes some basic public health in that it separates people from the virus. The virus has trouble getting from my infection to the next host. And if you do that, the epidemic will slow down, and if it slows down enough that we can then handle the caseload, that's when we'll have a better outcome from this epidemic. We can always do more to prepare. I would like to see testing expanded tremendously, and we talked a little about it in the session about how that is in the process of happening. Without expansive testing, you don't really know who's ill and who isn't. But in the absence of that, these types of public health measures that we just talked about are the next best thing to trying to calm the epidemic. So I think we will see a lot more cases. Will we see it as bad as Italy? I doubt it. But we have to worry about that as a possible outcome.